Helping Seniors Television, all about improving quality of life for seniors. If you're a senior, know a senior, or plan to be a senior, then this show is for you. It's all about helping you develop your own aging plan so you can age actively and with dignity. Helping Seniors Television from the Helping Seniors Network of information, education, and resources.
Now it's my honor to introduce Dr. Rosemary Laird with ClinCloud. And as I was saying before you got here, Joe Steckler, our president and founder, has always talked so highly about you. I mean, Joe is the guy who created the Brevard Alzheimer's Foundation. And when he retired from that, then he created us literally 15 years ago because he said there's more work to be done on behalf of seniors. And the work that you guys are doing at ClinCloud, I believe, is going to revolutionize everything for generations to come. So with that, I'm so honored to welcome Dr. Rosemary Laird.
Good morning. And no meeting of this group is can start without recognizing Joe Steckler, because I got to this community in 2002 and nobody really knew what a caregiver was. Many people had not heard or been affected by Alzheimer's disease. And thank you. And yet Joe and some others in his universe that he had pulled together were already working at the county level and then with the health systems to make sure that we had people paying attention to these issues. And it really takes that kind of work, as you all know, to make those sort of resources available and sustainable in any community. So here we are all these years later. And now, of course, many of us have been impacted by an illness like Alzheimer's disease. We're all a little older ourselves, aren't we? And we now can appreciate all the more this category of human activity called caregiving. And so we all share his appreciation and his understanding of that. So yes, thank you to Joe Steckler, and thank you for everyone who's here today. The cake has a volunteers shout out, and I know many of you are in that capacity, and I really, really appreciate your taking some of your time to focus on these kinds of needs. So, well, what I am excited to talk about today, so I am a geriatrician who came to Brevard County in 2002 to help the Health First system start some aging programs. There weren't any until that time. And a group of lawyers on the board at Health First, Cape Canaveral, are there legal folks in the room? We have them to thank for getting the aging program started at Health First, the board of directors at that time. So another group of really prescient people knowing that we should start then to be able to have services now. So that was the beginning of the Health First, what is now the Aging Services Program, with my good friend and partner, Dr. Viera, still sort of steering the way with that program, and all the others that have grown up with us in that time frame. And one of the pieces missing in Brevard County, we weren't missing a lot, but one of the pieces missing was clinical research, clinical trials. We had a pioneer, Dr. Kirk on Merritt Island, who was doing it for a long time, and their group is still working today. But beyond that, the vast majority of the county was not serviced by any of the clinical trial companies. And at some point, maybe about 15 years or so ago, the world realized that you can't get advances in pharmaceutical development quickly enough if you're only testing people who can show up at Shands Hospital or at Mass General in Boston, at the big academic centers. So we started having centers out in the community and having them become certified and licensed and regulated by the FDA. So it's still a very regulated and quality-driven activity, but it brings clinical research to where we all live. The majority of us get our healthcare in our community, not at places like the big tertiary medical centers. And so that's what they realized, and that started much of the progress. And Alzheimer's disease has been fortunate to be amongst the diseases that have had some progress. And so today we're all together here at a really important time. And we have ClinCloud here now for the last 4 or 5 years, located in Viera, at the corner of Spyglass and Murrell. And it's really allowed us to bring some opportunities to the community that we wouldn't have had. And I'm really excited about it because that's the jumping off point for what I want to tell you today. Some of you may be thinking, well, a clinical trial, I don't know. I don't want to be a guinea pig, and I don't want to go through all of that and get poked and prodded and everything. And gosh, I don't have Alzheimer's disease or anything like it. So would there really be any need for me to know about this kind of thing? Well, suspend those thoughts, and then let's talk about what we're going to talk about, and then we'll come to that question again at the end. So before I jump too much further, show of hands, who has been in your primary care provider's office and have been asked, hey, what have you done to keep your brain healthy lately? Just show of hands. Get them up there. No. Now, one, thank you. I knew there must be someone.
You're up.
No. Now, that was not planned. That was not planned. But thank you. Okay. So are you serious? You're not just shy. No one has asked you about what you've done to take care of your brain health lately. Okay, see? So this is why this is a problem. I'm going to tell you why this is a problem. None of us, myself included, have been paying attention to the health of the brain as much as we should. And there is some groundbreaking understanding and research that has gone on that helps us know now that the reality of Alzheimer's disease and similar diseases like that. So you may have heard of dementia in a variety of terms, vascular, Lewy body, Parkinson's disease related dementia. All of those illnesses, there's some understanding now that they don't necessarily have to end up like what we all know of them today. And that's what we're going to touch on. But it's going to take some paying attention to our health to make that happen. So on the next slide, let's go ahead. You're probably like, gosh, she's 10 minutes in and she hasn't even gotten to her second slide. Okay, so we're going to go to number, I was going backwards. The other left. Yay. Great. So I promise we're going to get through all of this. Lots of good information. The reason I'm saying that we need to think more about our brain is because our brain has one of two things happen. Well, possibly two things happen to it. It certainly ages, right? Every part of us does. And the brain has a particular type of aging that can happen to it. And it also can get disease. And we haven't necessarily paid as much attention as we need to both the aging process of the brain and the disease process of the brain. Fortunately, much of the research that's been done to develop medications to treat these illnesses is going to help us. So listen to this. Alzheimer's disease itself is an example of a disease. So repeat after me. Aging is not the same as Alzheimer's disease. If you are in an exam room and someone tells you, don't worry, that is what should happen because you're X, fill in the blank, 72, 67, 85, 90, be polite, but realize you need to get more help. Different help, because that is no longer, in my opinion, a professionally acceptable answer, especially if you're asking the question, do I need to do something more to take care of my brain? Or if you're bringing a symptom to someone. I used to kind of just let it go, but now I am serious. Do not let anyone tell you it is only because you are X age. That's like my next campaign. And the reason I'm saying that is because we know now these are diseases. Amyloid protein is the disease maker of Alzheimer's disease. It's an abnormally folded protein that does exist in all of our bodies. Some of us, though, do not manage this protein well. for a variety of reasons. Like, why does someone get arthritis and someone has a heart attack? For a variety of reasons, some of us do not manage the presence of this protein well, and it's able to accumulate. The picture you're looking at is all the nerve cells, a bunch of tissue that is supposed to be doing our thinking, one nerve talking to another sort of thing. If amyloid gets in there and messes up the transmission of one nerve talking to another, you can't think clearly. That's the disruption that happens. Now, amyloid plaque's only one part of the story. What it does, this misfolded protein, the other part of the disease of Alzheimer's disease is what you see up there labeled tau tangles. In an effort to help ourselves, our body does what it thinks is a good thing. It says, there's too much amyloid. I'm going to call tau to the rescue. Tau is a protein that on the paper looks like it'd be a good thing. It helps with repair. It brings the warriors of inflammation and cell repair to the scene. Unfortunately, it does it in too much. It has too much gusto behind it. When there's too much misfolded amyloid, you get an overdose of tau protein. In an overdose form of tau protein, what was good is now bad. And all that inflammation and irritation, you can think of it like, oh, today I actually have an example. I'm always pretending to have a scab on my hand. Today I do. It's like amyloid is a scab on your skin. Tau comes along and tries to help, but in so doing, it pulls that scab away. And what happens when you pull a scab away? It bleeds and gets angry, and it keeps the process going. That's what tau does. So those are disease states. That's not aging. That's a disease. That's why it's important not to let anyone tell you, oh, you're having this symptom. It's from aging. It may be, but you want to find out if it actually could also be from disease. You're not going to sit tight until you know whether it's from a disease or not, because there are now things we can understand about the disease of the brain that we couldn't before. Most of my career, the answer was you can't diagnose Alzheimer's disease. Has anyone heard that? Yeah. Well, now that's different. We can, and that's why you leave that room and you go find someone else if someone says that to you. What I want to move into now is this idea of, well, what would I do if I had a concern or if I had a loved one who had concerns? How would I know if something was just because I'm X age or if it's because of an illness? And one of the things I like to explain to everyone is that Alzheimer's disease is an example of an illness that has a very long and smoldering kind of start to it. It can be many, many years in the making. And so the point at which a symptom may appear is typically when we all start to get worried, right? That's when we or someone who loves us sees something and they say, well, now that needs some attention. We need to find out from someone, what this is. And that is why sometimes we end up being very worried about all of our senior moments, right? Anyone had them? I certainly have. Anyone said, oh my gosh, is that the beginning of Alzheimer's disease? I don't need a show of hands. I know. I'm very clairvoyant on this one. It's a human nature thing. So what I want to do today with this picture in mind is give you a couple of pointers about how you want to start thinking about this with regards to either yourself or someone you love. Because I do want you to leave today with a sense of, I'm not trying to panic anyone, but because no one else is talking to you about it, I do want you to leave with a sense of, well, maybe I'm in the clear. I hear nothing from that woman that makes me concerned at all. But maybe you might hear something and say, well, now that's interesting. I might need to get that looked at. Who knows? But let me give you the information. This slide is labeled a particular way that I really like. And it says it's a personal guide to Alzheimer's disease. one of the key lessons from today is that I want you to think about yourself and not your friends when you're thinking about this issue and your risk of something like Alzheimer's disease, because every one of us is very different. You see on the list some early signs, changes in short-term memory, personality or mood, and language skills. Those are 3 of the earliest signs of a change that could become a diagnosis of Alzheimer's disease. Some people, when they come to see me, have all 3. Some people only have 1, and it's not the one you think. It's not memory. It's the personality, or it's a mood change, or it's somebody who's stumbling over their words. These are the early signs to keep aware of, but I want you to be aware of them with respect to, has there been a change for me in the last few years in this area? So the reason I want you to remember the personalized is because whether you can keep up with your friends at bridge or golf or at the club or at church or whatever has no bearing. Whether you are different today than you were 3 years ago has a lot of bearing on this issue. It's really hard not to compare yourself to other people. My husband and I have races now to see who's going to remember something sooner. And of course, if you lose the race, you're like, oh my God, can't believe he got that one. And that must be me now. It's my turn to get Alzheimer's disease. So try to avoid that. But the point here, I hope everyone's getting it, is this is about you and how you've changed with time. And those 3 areas are the areas that are of most importance in the early changes of this disease. So you would want to sort of keep in the back of your mind if you've sensed anything like that. So on this next slide, in addition to understanding how you would think about the illness of Alzheimer's disease for yourself or a loved one, I want to open up this discussion to make sure that we're all aware of the range of things that we now know that impact the brain and make the potential for a disease like Alzheimer's disease that much greater. Risk factors is the terminology the medical world uses. And this is where I'm so excited to make sure that we talk about this more, because there is evidence of benefit to reducing these risk factors if you have them that can really change the potential of someone's risk for Alzheimer's disease. Now, the top row are probably the big 3. If you look at the data, high blood pressure and everything related to diabetes and obesity, the way our body manages that whole condition, those 3 things are some of the most toxic to the brain over time. We didn't know about the diabetes connection and the obesity connection until probably the last 5 years or so ago. And guess where it came out? In the research trials looking at the treatments for obesity. They figured it out. And then the scientists who work on Alzheimer's went and checked their notes, and they started comparing, and they started finding this connection. That's how clinical research helps all of us, is that back at the ranch, these scientists are putting together these different pieces of information that they glean from thousands of people in these clinical trials to help us understand how the body works. So that's been a very important advance. The next row are some that everyone wants to deny. Hearing loss. Who wants to raise your hand and say, yes, I'm having hearing loss and I'm very proudly wearing my hearing aid? Thank you. Thank you. I mean, just like me with my glasses, I tell people nowadays, just think of them as the AirPods. Everyone wears AirPods. Just put it in. But the evidence is very strong on this row. Hearing loss, smoking, and obstructive sleep apnea. The evidence is very strong that while those things aren't a direct disease of the brain per se, they are impactful in a very negative way. And in general, what we're trying to do is we've got only one brain to keep healthy. Aging does change our brain. What we're trying to do is not allow other things to change it on top of what's going to happen from an aging standpoint, because you can't really do much about aging. So these are the things that are in your control. And that bottom row are the things that are out of our control. Female, our genes from our family history and our age. So those are already done deals, right? Genetically, we're already predisposed. The important thing to understand about those pieces of information is that when people pay attention, there is research that shows even women, older people, people with genetic risk for Alzheimer's disease, if they pay attention to these other risk factors, their rate of developing Alzheimer's disease is lessened. Their rate of progression of Alzheimer's disease, if they get it, is lessened. So even my patients who have family histories, we've done the blood tests, they have a high genetic likelihood of getting this illness. There is now evidence that if they pay attention to these other factors that can make the brain less healthy, even if that Alzheimer's process takes hold and starts, there's a relative benefit to their overall brain health, if that makes sense. So you're sort of protecting your brain and improving its overall health, so that you've got sort of what's the term? You've got sort of a dam to hold back the damage if the Alzheimer's were to come in. See? Yes, she knows. And I think that page, I don't know if we're going to print out the handouts, but that could be, I don't know if we would or not, but we can probably, Rose, especially that risk page. Yeah, I really like that. We might want to start printing that one out. Okay. And then I added this slide mostly in case, I know it's too small to see, but again, maybe this can go on the back side, because what I also like to do with this, again, these are early symptoms. And what I like to do is give you a sense of changes that you can think about that do tend to happen early, because let's face it, we would all want to know about something like this as early as possible. So knowing about these sorts of things, I think can be helpful when you're thinking about yourself or your loved one. Now, and at the end, I can stay a few minutes if you've got specific questions about specific symptoms for yourself. The reason I keep focusing on early has to do with the reality of what we now know about Alzheimer's disease. When I was in medical school many, many years ago now, it was a disease of the old people. It was as if you didn't have to think about it until somebody was 65 or 70, literally. I was training to be a geriatrician, so it was like a big deal for me, right? But my friends, everybody, my colleagues who were going into different specialties, it was like, well, they didn't have to worry about that because it's the older crowd that's going to get this illness. No. Guess what we know now about when Alzheimer's disease begins? I got to go over here. The way this works, as you can see it, is this is when I'm, say, 40 years old. And then I'm 60, 70, 80 going that way. This is when I don't have any symptoms. This is when my first symptoms develop. So between here and here. This is the line of changes of disease happening in my brain. You guys can't see it, but at 40, I'm sorry. 40s, 20 years before we think it could be further back. The science so far says it's at least 20 years back. That the brain starts changing, not aging. If you're going to have Alzheimer's disease, it's a disease that's setting in. Going back to what we learned about, I shouldn't go that close. Going back to what we learned about the difference between aging and disease, right? So yes, the brain is aging, but for some of us, a disease is setting in way back then. that's why, for me, I'm like, yes, your doctors should all be talking to you about your brain health. But this information is literally just becoming known, and it's starting to make its way out into the world of the medical providers. And so it's starting. We know about it at ClinCloud a lot earlier because the research is going on. And we're starting to have research that is for people who have no symptoms whatsoever. And in part, it's because of what the scientists know about this process of, despite having no symptoms, there are people who may be at risk for this to be happening. And you can't detect it in day-to-day life, but we can detect it in other ways. So that's why I keep talking about early so much, is because much of the evidence that is coming in suggests, as you probably could imagine, that if we knew someone was at risk for Alzheimer's disease or one of those illnesses, and we interrupted, or we somehow were able to slow that process or even stop it, hopefully, who's the youngest person in this room? I think it's Rachel. So I'm hoping in Rachel's lifetime, she will see that we can stop it. Then there's a lot of motivation to find out early, isn't there? Because once our brain is affected, there's less ability. And the older our brain is, just like the rest of our body, the harder it is for an older body part to improve or get better. Unfortunately, we all probably know that. It's just harder. So you want to find and fix things earlier. So that's the reason early is important. Are you stretching or do you have a question? Okay.
Are we offering like medication or what's going on?
Excellent question. So now she was a plant. No, I'm just kidding. Thank you. I'm going right there. You read my mind. So what the question was are we offering treatment or medication, or what's happening there? There is actually, I'm going to go to the next slide. Yeah, this slide. There's both things happening with respect to treatment, but also I mentioned we try to meet people now who don't have any symptoms, because there is research about diagnosing. So research is all about answering unknown questions in medicine. So one unknown question is, how do we stop Alzheimer's disease? And that primarily is leading to the development of medications. But there is also an unknown question of, how do we diagnose Alzheimer's disease in its earliest stage? So there are research trials focused only on how do we diagnose. So for example, for a long time, we thought a picture of the brain was the only, we thought fluid from a spinal tap was the only way to diagnose it. I'm very happy to say we've evolved. Then we moved to a picture of the brain called a PET scan, an amyloid PET scan. Now we're moving to, you'll be happy to know, a blood test. They're close, pretty close, but not 100% through the FDA approval process of a blood test. So most likely within the next year or so, that will become much more available. A blood test that helps us know about risk for Alzheimer's disease.
What's up with the grass?
No. That's where the doctors come in, and that's where all the research still has to happen. And that's kind of why we're here today, is there are trials going on right now looking to find people who may have no symptoms or have early symptoms, but have evidence of these markers of illness that the research looks for are called biomarkers. Actually, that's not true. A biomarker is anything that we can learn about your body. So your weight, your blood pressure, how far your eyes can see, those are all biomarkers. A PET scan or a blood test is called a biomarker. So that's where you'll read about trials that have to do with biomarkers of Alzheimer's disease, and that's part of what we're doing. Because in my little picture here, that little tube there of blood, look when that is being tested, that's at the 20 years before stage. The diagnosis is still being made over here. So we're still learning, but we're trying to find people early. Now, it's a whole big, it's a whole nother conversation, because not everyone who gets told they have a blood test that says they're at risk will get full-blown Alzheimer's disease in their life. So it isn't, the science is still in a intermediate phase, I'd say. So we know that most of the people will, but not all. So doctors, other providers who help people learn about these results and what it means for their life are all also in the process of learning all about this. There's been a lot of new educational material out for physicians like me who are needing to talk to people and explain what these tests mean. So it's an advance, but I don't want anyone in the room, please don't go anywhere and say, Dr. Laird said there is a blood test coming and it's going to answer everyone's questions.
What?
No, it's going to help us. It already has. But it needs to be interpreted with a full context of your life. So that's just my personal opinion, but the science is behind that. So, but to the point of our friend who asked the question, we do have trials of all this sort at ClinCloud because the science is still at that phase. We still need to research and say, what's the best way to treat? We still need to research and say, what's the best way to diagnose? And being involved in a clinical trial typically involves these days going through everything we talked about as far as diagnosing, as well as potentially being offered a medication. But when you come to ClinCloud, the gentleman mentioned he came and you probably had a set of questions asked. You know, you had to count backwards, you had to do different mental gymnastics. And that's the first step, really, of any evaluation we do, because it really does. I know it seems like, well, how could 30 questions really help? But I've done this exact assessment a very long time. And true story, I mentioned I got here in 2002, hired by Cape Health First, stationed at Cape Canaveral Hospital. Well, guess what? What industry grew up in Cape Canaveral that would have people still there in 2002? What is the business of Cape Canaveral and that whole Space Coast? Hint, Space Coast. Yeah. When did people start moving to Cape Canaveral, Florida? 50s, 60s. How old were most of those people getting those jobs and putting those rockets on the moon? 20, 30? Do the math. Who was I seeing when I first got to Cape Canaveral? Rocket scientists, literally. At that time, there was another assessment used very commonly, and they were all getting 100 on it. Like literally, I couldn't find anything wrong in anybody, but I knew some of them were having trouble. So luckily at the time, a Canadian doctor had just published an assessment that was better for people who had privilege and access to more education and who had different professional pursuits. So I was able to have an array of testing available so that if someone came to me who had a certain level of education, I could use that assessment. So we gauge these assessments now, going back to what I said earlier, personal. This is about what your brain is able to do over time. So when I had someone who had the benefit of education, I used one study. If I had someone who had a different experience, I used the other because I needed to see what their capacity was. And then what did I do? I had them back 6 months later, and I could start to tell the difference. And some of the people fell off their curve. And that's how back in the day, we knew that someone was in trouble, is we watched them proceed to, unfortunately, decline on their assessment. That was all we could really do. Literally, that was it. We talked to the families and learned what they were observing, but that's how we diagnosed. Fortunately, we've moved on. Nowadays, I talked about the blood test. There are much improved MRI scanners and PET scans that I talked about. Some of you may have heard of PET scans for cancer patients. These are different. These involve looking for those abnormal proteins I mentioned, amyloid and tau. And the cerebrospinal fluid is still involved in research. Occasionally, some doctors will order that as well, but less often nowadays. So don't let that scare you to not go and get evaluated. There are ways. A lot of people think, well, it's my brain. They're going to have to do a spinal tap. And when I tell them, no, we don't have to do a spinal tap, they're quite relieved and willing to go through an evaluation. I don't blame people. It's a reasonable thought, and I don't blame them. But I do reassure them, no, we don't need that. We have other ways to help you these days. So that's the array of things. Some of them are involved in a research setting. Some of them are involved if I have someone come to my private practice, we might do them too. And they're all related to looking at the brain to see what changes have happened and where, because we know what happens from an aging standpoint, and research has now showed us what happens from a disease standpoint. And unfortunately, with the disease, there are certain parts of the brain that change, and our radiology doctors can now start telling us that this brain has this particular change. PET scans, similar, I kind of talked about those as well. So with respect to treatments, there are new treatments. You've probably heard of the FDA-approved treatments that are available now. They are available for people with early to middle stage illness, along the lines of what we talked about, where it's important to try to treat people early. The FDA only approved them for people in the earliest stages. So you may have, I'm talking about the two at the bottom, these most recent ones, lecanemab or Leqembi, and donanemab or Kisunla. Those are the two that are most recently approved. They, unfortunately, are not the treatment the cure I was talking about happening in Rachel's lifetime. They, as some of the other medicines do, they slow progression of the illness, so that about 30% slowing is what is reported in the literature relative to someone who did not take the medication. And from a time standpoint, they believe that that equates to about 18 months of extended abilities from a cognitive standpoint. But those individuals did still eventually return to a pace of having change over time when the medicine was stopped. So we're still learning about those medicines. And in a unique twist, most of the time, if you go to Walgreens or whatever pharmacy and you get a drug, that means the FDA's done with it. They approved it. They said it's safe and it works. They're done. They don't do anything more. With these two drugs, they approved it, but they said, we're also going to keep an eye on this. And everyone who gets it is in a registry to make more assessments on both benefit and risk. There are some higher risks with those medicines than we've had in other medicines for Alzheimer's disease. So it's important to talk to your provider about that. The medicines, one thing I want to point out is the medicines above here, these top four, do you see the last one, 2003? And then when was this new one, 2023? You can do the math. It was a dry spell. Dry spell. So we had, for most of my career, we had two oral medicines that helped about half of the people who take them have a slowing of about 18 months. It was a similar sort of slowing, and it only worked in about half of the people. The benefit of these new IV medicines, relatively speaking, is that most people get the benefit, not only the 50% who did. Still challenging medicines. I don't have time to talk about it today, but the side effect profile of the two new medicines is much different and much higher. So it needs its own conversation with your personal physicians. The medicines that have been around for a long time are available for every stage of the illness and have far lower side effects. So many times those are what we use, especially if someone already has somewhat advanced illness. In the research world, you are most likely going to encounter this type of medicine, the newer type of medicine, and I hope I have the next slide. The next generation of medications that are coming out have to do with, remember back when I said amyloid is the instigator of all the trouble. But when it gets into the picture, it brings about the protein that causes all that inflammation, tau. So now a lot of people think that tau is actually the real problem maker. And if we can quiet tau, which was the one causing all the inflammation and destruction, we may be better off. So there are now a lot of research lines looking at that protein, anti-tau they're called, instead of anti-amyloid. And this is what much of our research at ClinCloud now has shifted to. Because research is just it's you remember science fair in school? Any of you have science backgrounds? You know, it's one hypothesis after another. And so now our hypotheses are evolving, and we need people to help us evolve these hypotheses, because quite literally, you do not get these medicines at the FDA even to be discussed unless they can fill their trials and have the evidence that they need. And I've done this now for almost 6 or 7 years, and the level of scrutiny of the FDA over these trials is impressive, more so than I ever imagined. I actually had the privilege of having a discussion with one of the officers of the FDA, looking at some of our materials, our data, looking at how we proceed and do things. And it was really reassuring because they were asking really good questions about the quality of our clinical trials. And they do that all over the country. So it's, like I said at the very beginning, we had to move out of the big medical centers into places where we all live. But I also believe that that makes it very important for us in the community setting who are doing this kind of work to make sure that we give back to our community with the quality this deserves. These are very important health issues for people, and this research, as important as it is, we also have to make sure that it fits well with our patients, our subjects' health. And so that's my role, and my nurse practitioner's role is to, have you come and see us at the clinic, see what your situation is like, see if you may be a candidate for a trial. After that's done, you're given an evaluation with one of us, the physician or the nurse practitioner, and we think through how does this fit within your health in general to make sure that from a safety standpoint, we know what the medicine might do, but what kind of health or other conditions might you have that could make you either a good candidate or not so good candidate. So we pay close attention, and we also try to connect with your own primary care providers or other specialist providers to make sure they're aware. Because ideally, this would be done within the context of your overall medical care, which I know can feel kind of, scattered sometimes, but we try to make some lines of communication. Yes. Well, that's a great question. And the good news is you don't pull out your insurance card when you come to see us. So the pharmaceutical companies pay all the costs of this. So even those tests I was mentioning, it's all covered by the pharmaceutical company. Now, I have to put a little asterisk there because in full transparency, anything you do for a clinical trial, even your data, your scan, the results of your blood test, is the property of the people who are paying for it, the clinical trial company, because they're responsible for that data. So you actually can't get some of it. You get informed in certain ways. And at the beginning of a trial, people like Rachel go in a painstaking way through exactly what information you will or will not be given access to as you proceed through the trial. The people at the pharmaceutical companies know perfectly well that this is a joint effort. They need to make a trial that's scientifically sound, but they know that this is about people and people's lives. So I have observed they're trying to find a good balance between what they release and what people need and what they need as far as quality of their data. So I just want to make that sort of general statement. In general, you do get the major answers. Do you have signs of Alzheimer's disease or not? You may not get the detail of a test, but you also are not paying for it. And you're given full informed consent ahead of time so that you have to really show that you understand what you're signing up for. So I think it's a good process and fills a lot of needs with some quality and safeguards. So yeah, it's a good question. All right. I think you had a question and then I saw your hand out of my corner of my eye. So I'll ask this gentleman and then you're next.
My background is health educator, and I'm real familiar with risk factors for a lot of diseases. My concern right off the bat is, does your assessment or evaluation differentiate between ADD and symptoms for Alzheimer's? Because looking at your chart, they're almost identical.
Yeah, so that's a really good question. And in this day and age, all of us grew up in a time when ADD wasn't being diagnosed, wasn't being looked for. None of us had that the young people have now. So there are individuals who, of course, there are people who were undiagnosed with that condition. In a screening sense at ClinCloud, you are there. Our process there is not a full and comprehensive medical evaluation. It is a clinical trial evaluation, which is a abbreviated version of a full comprehensive medical visit. If someone were to come to us with that background, we would do our protocol. Again, based on their background, we would choose our testing. But one of the investigators would probably also say, no matter what our findings were, if you have symptoms, this, that, or the other, or if you voice that concern, our type of assessment at a clinical trial center is not a full comprehensive assessment. And we would, just like today, I got asked, who are the people in town who do those kinds of assessments? It's called neuropsychologist. So those are PhDs. Health First has 2 wonderful PhD neurocognitive experts, and they do what are called neuropsychological assessments, which includes looking for things like ADD and cognitive impairment. We are only going to do the cognitive impairment part, but we try to answer questions of that nature and make sure you're connected somewhere in the county with someone who can provide that other help.
Risk factor from accidents like concussions, and I read that there's a lot of correlations there. Can you talk about that? Or
Sure. No, that's a good point. There is evidence. There's 2 things. There's evidence from the world of sports and head trauma and football, soccer, etc., and of the potential for damage later in life from early concussion. There isn't as much known about that, about why some people, not all football players, end up with the same problem. Some do, some soccer players. So there isn't as much known about what to do to impact that. So my list here is primarily thinking through the places I can make an impact. Now, to the gentleman's point, one thing is if you're a bike rider or if you're a skier, putting your helmet on is a good example of brain health. So I probably should get that back on my list. So thank you. But we don't have as good a knowledge on the science of why early trauma can make for later brain trouble. Yes.
You had said at the very beginning, what do you do for your brain health? Does your doctor ask you about that? And of course, you said the three main factors with the blood pressure, the diabetes, and then the obesity, those were the three things. So if you're taking care of those, that's helpful. What else can we do to work on the health of our brain?
Yeah. So the main thing I'll refer you to, there's two places. You can go to the Alzheimer's Association and they've got a good, but there actually was, and I don't know if it's out yet. Maybe somebody can Google. There's a Lancet Commission 2024 has 14 of this is the latest of their recommendations, 14 areas where you can make a difference in your brain's health that have evidence behind them, showing that if you pay attention to these things, you can improve and reduce your risk. So Lancet, LANCET 2024, the Lancet Commission 2024. Main thing that we haven't talked about today is physical activity. So of all the things that people have studied looking at keeping the brain healthy, it's physical activity is top of the list. So that activity and its effect on circulation is probably the most important thing. 30 minutes a day minimum of a moderate activity. Am I overstaying my welcome?
Yep.
Oh, that is nice. The Activate is good. That was back in the time when it was 8 things. Now you have to be even more intentional and do 14 things. But yeah, Activate's a good start. Yeah.
I wanted to make sure that if they're interested in.
Oh, yes.
We have Rachel here today. So on the heels of Dr. Laird wrapping up her presentation, if you are interested in setting up an appointment with us to do a memory screening or find out more information about any of our clinical trials, that's why she's here today.
I'm Joe Steckler. Thank you for joining our program today. I'd like to remind you that our senior information line is available to you at 321-473-7770. There you can get help and direction that could be helpful for your specific situation or circumstances. The work of helping seniors is very important, but we can't do it alone. That is why our sponsors here in Brevard County are so important. I'd like to thank our many area sponsors, businesses, and medical providers who support the mission of helping seniors that help us carry the cost of our media efforts. If you'd like to join us either as a business partner or simply donate as an individual, we welcome your call at 321-473-7770. You are always welcome to visit our website at www.helpingseniors.brevard.org. Thanks so much for your help. It does make a difference.